Welcome to Concept in Medicine. In this tutorial, we are going to be studying and learning concepts regarding the cardiovascular system, part 2. And this concept is going to be based on the heart murmurs. Kindly subscribe as we proceed. Let's begin. So when we talk about murmurs, you should know that murmurs are definitely not normal sounds. They are going to be abnormal sounds that are going to be produced during the contraction and relaxation of the heart. So when we say murmurs, simply put, they are whooshing sounds produced as a result of turbulent blood flow. What that means is that when you have blood flow through a narrowed opening, then there will be turbulence. So let's take ourselves back into the world of physics. If we take a blood vessel, what flows through the blood vessel is going to be blood. So you have the blood flowing in this direction. The blood molecules do not touch each other. They are moving in straight line. When that happens, they will refer to this as laminar flow. But as you proceed, should you proceed where there's a narrowing, what is going to happen is that the molecules will start colliding. And as they start colliding, they generate what we call turbulence. And in that manner, it's regarded as a turbulent blood flow. So that is what we mean by turbulence. You see flow of molecules, flow of fluid through a narrowed opening or through an opening which has become so small. I hope you got that. Now let's proceed. To study about murmurs, we are going to use a technique. And this technique is going to help you conceptualize facts about murmur. It will make it easy for you to understand murmurs. So let's have a look at that concept. So this technique, we will be referring to it as Citylara, where the Citylara has its connotations. So the C stands for the character, the T for timing, the L for loudness, the A, area where loudest, the R for radiation, and the other A for accentuating maneuvers. So we are going to be taking them one by one, and that would help us break down the murmurs. So let's begin with the character and the timing. So before we look at the Citylara technique, let's have a look at how the heart functions again. You should know that the heart cycle is comprised of the systole and the diastole. What do I mean by that? What I mean by that is that the heart contracts in systole and relaxes in diastole. It means the chambers of the heart. You are looking at the atria and the ventricles. But mostly because when the ventricles are more muscular, they are going to be experiencing much of that, even though the atria do experience same. And one thing you have to know with regards to this drawing is that, so if you watch our previous series with regards to the cardiovascular system, we spoke about the heart sounds. And for the heart sounds, we made reference to how the heart works in systole and in diastole. One thing you recognize from that video is that the systolic phase of the heart cycle is always shorter than the diastolic phase. And in this diagram, as you can see, the systole is kind of shorter than what? The diastole. The diastole is longer, and this is to accord the heart muscles enough time to rest after a hard day's work. Because if they don't rest, what will happen? The next systolic phase, the next systole, where they are supposed to contract, they will become restless. That is why the diastolic phase is much longer than the systolic phase. I hope that makes sense to you. And in that video too, we made mention of the first heart sound and the second heart sound. With regards to the murmurs, we are going to be using the understanding of the first and second heart sounds to get a concept. We said that the first heart sound is produced as a result of the closure of the mitral and the tricuspid valve. Meaning that any time you look at the mitral and the tricuspid valve, you should know that in this case, they are going to be brothers. So in the case where you have a deficiency of any of these valves, that is the mitral valve and the tricuspid valve, if the member is heard in systole, it is going to be the same for both. If mitral, an example, if you take mitral regurgitation, the member is going to be heard in systole. It means for tricuspid regurgitation, the member is still going to be heard in systole, because during the production of the first heart sound, both of them closest to produce that sound, known as what? The first heart sound. So in case of any member, they would be elicited with regards to timing in the same phase of the cardiac cycle. The same thing applies to the aortic valve and the pulmonic or pulmonary valve. We said that the second heart sound is produced as a result of the closure of the aortic and the pulmonary valves, which together collectively known as the semilunar valves. So if they are closing together to produce the second heart sound, then should there be a member with regards to a deficiency of their valves, they will be heard in the same phase of the cardiac cycle. Now, let's go back to the murmurs. Using the Citylara technique, let's look at the character and the timing. So with the first one, we are going to list several murmurs, and we are going to look at their character and timing. And with that regards, even look at the causes of these murmurs. So let's take the first one, which is the ejection systolic murmur. With that, it tells you that during systole, the ventricles are supposed to contract. And when they contract, they are supposed to eject blood. So if you look at that very carefully, you will note that, look at the left ventricle and look at the right ventricle. Which blood vessels are emanating from them? If you take the left ventricle, you realize that the aortic valve is here, serving as what? A unidirectional flow, ensuring that there's a unidirectional flow of blood. If you look at the pulmonary artery too, is here with the pulmonic valve or the pulmonary valve. So we have the aorta coming from the left ventricle, and we have the pulmonary artery coming from the right ventricle. So if the left ventricle and the right ventricle contract, what do? They eject blood out of their chambers through the aorta and the pulmonary artery respectively. To where? Through the aorta into the systemic circulation, through the pulmonary artery into the pulmonary circulation, telling you that blood is pumped out from these chambers when there is contraction. So how does the blood get out? It is ejected. So it tells you that in this case, we are not going to be talking about the mitral valve or the tricuspid valve. Rather, we are going to be talking about the aortic valve and the pulmonary valve. Now, with regards to the ejection systolic murmur, what is the character? So in that case, the character becomes what? The ejection, okay? It becomes the ejection, and the timing becomes what? Systolic. Means that the timing is always in reference to which phase of the cardiac cycle you would hear that murmur. So in that case, the character becomes an ejection, the timing becomes what? Systolic. And usually, for ejection systolic murmurs, they can be described in a particular manner. That is a crescendo-decrescendo murmur. So the ejection systolic murmur can be described as a crescendo-decrescendo. Crescendo means you are climbing, decrescendo means you are descending. And in that order, we can, explain that crescendo-decrescendo nature of it can also be described as what? A waxing and waning character, meaning that it waxes, that is, it's climbing up, and it wanes, meaning it is descending. So the ejection systolic murmur has that kind of what? Waxing and waning pattern, also known as the crescendo-decrescendo. So for the ejection systolic murmur, you should know that it is going to be in systole from the name, and it's as a result of ejection. And it will have the crescendo-decrescendo pattern as described in this diagram. So if you watch very well, X1 is heard at the beginning of systole, X2 at the end of systole. And between X2 and X3, you have the diastole. So if we are supposed to place this member, it's supposed to be in what? Systole. And it's going to be a crescendo, ascending and descending pattern. And this will define the character and timing of the ejection systolic murmur. Now, so let's talk about the causes of an ejection systolic murmur. For the causes of an ejection systolic murmur, we are going to look at the two groups of causes. So let's look at the causes. The causes can be divided into two: the innocent causes and the organic causes. The innocent means that, it's more like a physiological cause. It doesn't draw a worry. But for the organic causes, yes, you should be worried. For the innocent causes, you should know that an ejection systolic murmur may be innocent in children and also in high output states. Which high output state are we talking about here? Pregnancy and tachycardia. And for the organic causes, remember the mnemonic HAB. HAB, A, with the HAB, the A is to the power 2. So HAB with A squared. So for the HAB, the H goes for hypertrophic obstructive cardiomyopathy. That's HOCM. The A, aortic stenosis. And the other A, aortic sclerosis. And finally, pulmonary stenosis. So the trick here is that once you have aortic stenosis, then you should know that for the pulmonary valve, it is also going to be a stenosis because the two contribute to the second heart sound. So as such, they are brothers. Whatever is happening to A will happen to B. So whatever is happening to the aortic valve in stenosis will happen to pulmonary valve in stenosis, because when they are stenosed, definitely there's going to be turbulent blood flow, and that will generate the murmur. In which phase of the cardiac cycle? Systole. And the ventricles are going to be contracting to be ejecting blood. And it is as a result of the ventricles ejecting blood that the turbulence will be generated. So in that case, we will say it's an ejection systolic murmur of a crescendo decrescendo pattern. It means it waxes and wanes, it rises and falls. Now let's move ahead. Let's move ahead to the next murmur. So let's move to the next one. That is the pansystolic murmur. So in this case, the character and time is going to be pansystolic. Why am I saying pansystolic? It means that it's going to be heard throughout the phase of systole. And you should know that for the pansystolic murmur, it's of uniform intensity. So if you look at the drawing, you realize that the height of the murmur is the same across. It's of uniform intensity, and it merges with the X2. You see that it ends exactly at the X2, at that same intensity. It doesn't go down. It is only until the systole is done that it ceases to be heard. And for the pansystolic murmur, always know that it is usually organic. It means that the causes are going to be organic. There is not going to be a physiological meaning to it. And for the causes, you can think of the mitral regurgitation, a tricuspid regurgitation, and ventricular septal defect. Now, let's look at why it is such. If you look at the mitral valve and the tricuspid valve, ask yourself, if you have a mitral valve insufficiency or a tricuspid valve insufficiency, that is a mitral regurgitation and a tricuspid regurgitation, what are you going to witness? If you watch the valves, we said in our previous video with regards to the structure and function of the heart. That's the first series, the cardiovascular, the first video. You will notice that we said that valves, usually, their function is to ensure a unidirectional flow of blood. And you should know that the direction of flow of blood from the atria into the ventricle is always going to be like this, from the atria to the ventricle, and not the other way around. So if you have a mitral or a tricuspid valve insufficiency, then it means that this valve definitely, instead of it being closed, it is not shut properly, leaving an opening. Then you ask yourself, when will the blood be able to go back into the left atrium? Is it not when the pressure in the left ventricle is greater than the pressure in the left atrium? And when can that happen? Definitely, it is when the ventricle is contracting, meaning that it's going to be in systole. So in that case, once the ventricle is contracting, the pressure generated, portion of it would push the blood through the aorta to go into the systemic circulation. But again, portion of the pressure will be forcing the blood to move through the deficient or insufficient mitral valve into the left atrium. And you should remember that the mitral valve has closed, all right, but it is not completely closed, leaving an opening, leaving a narrowed opening, leaving an opening which is very narrow. So if blood is flowing through, as I said from the introduction of the video, if you have a flow through a narrowed opening or narrowed orifice, there's going to be collision, and that generates turbulence. So because of that, a turbulence will be generated, and that is the murmur that we are talking about. And it is only until the left ventricle stops contracting that you will not be able to hear the murmur any longer. And when does it stop contracting? When the systole is done and the diastolic phase is about to begin. So in that manner, we will say that the murmur of mitral regurgitation or triscopic regurgitation, they would have a pansystolic character and timing. And for the ventricular septal defects, it means that there's going to be a communication. There's going to be a communication between the ventricle and the ventricles. That is, there's going to be a communication between the two ventricles. That's the right ventricle and the left ventricle. So in that case, during systole, what will happen? Again, there's going to be ventricular contraction. And you should know that the left ventricle is more muscular than the right ventricle. So in that case, what is going to happen? You will have more pressure generated in the left ventricle than the right ventricle. And you should know that flow will move from the region of higher pressure to the region of what? Lower pressure. And if that should happen, it means the flow is going to be from the left ventricle to the right ventricle. And it's going to be through a narrowed opening. And again, turbulence. To add on to why during mitral regurgitation, the murmur is heard throughout systole, is that when the left ventricle, or let's say triscopic regurgitation, so let's zoom in on just one, that is the mitral regurgitation. The left ventricle will generate pressure, all right, but because they are opening at both sides, that is the aorta and the insufficient mitral valve, so there's a law in physics known as the Pascal's law. It's with relation to gases, which states that pressure applied at a point in the gas is equally distributed in all directions, provided temperature and volume remains the same. So if that is the case, if the pressure generated here, we have a focus like what I've just demonstrated here, then you should know that it's going to be moving in all directions. All directions. And these directions means that any opening that is available, the blood will be able to flow through. And the openings here for the mitral regurgitation, we have the mitral valve, which is not well closed, and we have the aorta, which is naturally open to receive blood. I hope that makes sense to you. Okay. Let's move ahead and look at the other murmurs. Let's look at the next one. That is a late systolic murmur with a mid-systolic click. So simply put, it means that it's going to be happening at the end, towards the end of systole, and it will come with a mid-systolic click. And this particular murmur is heard in mitral valve prolapse. Let's move on to the next one. So the next murmur we want to talk about is the mid-diastolic murmurs. For mid-diastolic murmurs, always remember that they are low-pitch murmurs. And if they are low-pitch murmurs, which portion of the stethoscope should you be using to listen to the murmur? Definitely it's going to be the bell of the stethoscope. Why am I saying that? Because if you look at the stethoscope, there are two portions that you can use to listen to the sound, the heart sounds and the murmurs. That is, we have the diaphragm and the bell. The diaphragm is the one with the membrane, the one with the plastic membrane. What does the diaphragm do? The diaphragm usually filters out the low pitch sounds, making the high pitch sounds easily heard. But if you take the bell does not filter. It listens to the low pitch sound. And when you are using the bell, to make sure you don't apply it firmly onto the skin, you place it on the skin gently and not firmly. Why? Because if you place the bell of the stethoscope firmly onto the skin would be serving as another diaphragm, filtering out all the low pitch sounds, making them not to be heard. So at the end of the day, you are not going to hear any sound. So always note that the mid-diastolic movements, they are low pitch. And another thing is that they are rambling. Okay? And from the name, mid-diastolic, meaning at the mid portion of diastole. So if you watch this diagram very well, we divided it into two. In diastole, which is between X2 and S3, we are the middle. And at the middle, what are we seeing? We are seeing an elevation, then a depression, then another elevation. The first elevation that we are seeing there is what we call an opening snap. And for opening snap, it just tells you that what? The mitral valve, or whatever valve that is involved. In this case, we are talking about the mitral valve. The opening snap usually happens in mitral valve deficiency, like stenosis. So for the opening snap, it depicts a pliable or non-calcified mitral valve. So simply, the opening snap depicts what? A pliable or non-calcified valve, meaning that the valve is not calcified, but rather it is just hypertrophied or it is just thickened. And that is what is causing the narrowing. So in that regards, we will say that the mid-diastolic members, they are low-pitched and they are rumbling. And in addition to that, they will be heard towards the mid portion of the diastole. And in that regards, they will have an opening snap. And getting closer to the end of diastole, there will be what? An increased loudness. And that one, we call it PreSystolic accentuation. When we say accentuation, is to make loud. So towards the end of the diastole, the murmur sound would what? Increase in pitch. It will increase in intensity. And that is what we term as the PreSystolic accentuation. As we can see in the diagram here, we have the PreSystolic accentuation. Now, let's talk about the causes. For the causes, we can think of the first one as mitral stenosis, and the second one, if it has happened to the mitral valve, then definitely the tricuspid valve. So it's mitral stenosis and the tricuspid stenosis. Then again, with regards to the mitral stenosis, there are causes of mitral stenosis. One of them is rheumatic fever. So if you are hearing a mid-diastolic murmur, a rheumatic fever, of course, it's because the mitral valve has become stenosed. But again, if the mitral valve stenosis is caused by a rheumatic fever, the murmur is not only referred to as a mid-diastolic murmur, but it is referred to as the Carey-Coombs murmur. Let's have a short word on Carey-Coombs murmur. So when the mitral stenosis is as a result of a rheumatic fever, even though the murmur that you are going to hear is a mid-diastolic murmur, but of course, since it's caused by rheumatic fever, definitely to have a special name. And in that regard, we'll call it the Carey-Coombs murmur. And for the Carey-Coombs murmur, it is due to the thickening of the mitral valve leaflets resulting from the deposition of vegetations. And those vegetations, definitely, they are going to be as a result of the rheumatic fever. So if you have a mid-diastolic murmur in rheumatic fever, note that its special name is the Carey-Coombs murmur. So if you don't see mid-diastolic murmur for rheumatic fever, look for Carey-Coombs murmur. It's a mid-diastolic murmur. It is also going to be what? Low pitch and rumbling as well. Now, there is another special cause of a mid-diastolic murmur. And this one, because of that, I am using an asterisk at both sides. And that cause, we call it aortic regurgitation. Meaning that, if you watch very carefully, in aortic regurgitation, what is going to be happening? The aortic valve is not completely closed. So what will happen is that during ventricular diastole, when the left ventricle is in a state of relaxation, what will happen is that the weight of blood above the non-properly closed aortic valve would make the blood fall under its weight into the left ventricle. And as it's falling into the left ventricle, remember that during diastole, the left ventricle is receiving blood from the left atrium. So it would have been filled with a certain level of blood. So as the blood falls back into the left ventricle, it will be what? Splashing onto the anterior valve caps of the mitral valve. So if that happens, it creates that turbulence. And it is doing that because a certain level of blood has already collected in the left ventricle. So because of that, we can see that in aortic regurgitation, there is going to be flattering of the anterior valve caps. That is the anterior mitral valve caps by what? The regurgitant stream of blood, the blood that is returning from the aorta as a result of an improperly closed aortic valve. And when that happens, even though we say that it's a mid-diastolic murmur, but we'll give it a special name. That special name is Austin Flint murmur. So Austin Flint murmur can be elicited in aortic regurgitation. And that aortic regurgitation will cause the flattering of the anterior mitral valve caps by the regurgitant stream of blood. I hope that makes sense to you. Let's move on to the next murmur. So the next murmur we are going to be looking at is the early diastolic murmur, and that will be our last type of murmur. You should know that the early diastolic murmur is loud in intensity, but the only problem is that you could easily miss it whilst listening to the patient's heart. Whilst listening to the patient's heart, easily miss it whilst listening for it. Why? Because it happens in early diastole. So how do you ensure that you don't miss it? All you have to do is to listen for silence at the beginning of diastole. At the beginning of diastole, listen for silence. And if you are listening for silence at the beginning of diastole and you hear any other sound, then that becomes the early diastolic murmur. And if you watch the diagram very well, we have our systole here and we have our diastole. You will realize that just at the beginning of diastole, you will see the early diastolic murmur. So that diastolic murmur that you see at the beginning of diastole, we call it the early diastolic murmur. And once again, remember that it has a loud pitch or it's highly pitched, but you could easily miss it. Therefore, always listen for the absence of silence at the beginning of diastole. Let's move ahead and look at the causes. For the causes, there are two: aortic regurgitation and pulmonary regurgitation. And for the pulmonary regurgitation, it is not so common. Now, let's go back to this. Let's explain why pulmonary regurgitation, why aortic regurgitation. Why are we saying that? Bear in mind that the aorta, which is having the aortic valve, and the pulmonary artery, which is having the pulmonary valve, both drains blood from where? The ventricles. And you should remember that during diastole, the ventricles are not pumping blood. They are in a state of relaxation. So if either the pulmonary valve is not well closed or the aortic valve is not well closed, then blood will be falling from the system under its own weight or from pressure in the system through the deficient opening in either the aortic valve or the pulmonary valve into the ventricles. That is, if it's the aortic valve, you are going back to the left ventricle. If it is the pulmonary valve, you are going back into the right ventricle. and that turbulence will generate the murmur. And it's going to happen very early because in early diastole, the pressure effect is much felt. That is why it is going to be early diastole. The pressure effect from the system is much felt. That is why it is going to be what? Early diastole. I hope you get that. Now, let's move ahead. We made mention of the causes being aortic regurgitation, which is more common, and pulmonary regurgitation, which is rare. It is not so common. For certain scenarios, if you have a pulmonary regurgitation, which is secondary to a pulmonary hypertension, resulting from a mitral stenosis, then it produces an early diastolic murmur known as the Graham-Still murmur. Graham-Still murmur. The Graham-Still is a special type of murmur which is produced from a pulmonary regurgitation secondary to a pulmonary hypertension resulting from a mitral stenosis. Now let's explain that. Now, if you have a pulmonary regurgitation, it means that blood will be flowing back into the right ventricle. Then again, we said it is secondary to pulmonary hypertension, then resulting from a mitral stenosis, meaning that in this case, the primary cause, the primary unit there is what? The mitral stenosis. So that's going to be between the left atrium and the left ventricle. So if there's mitral stenosis, it means that the left atrium will not be draining blood quickly from its chambers into the left ventricle, leading to congestion of blood in the left atrium. And as a result of that, there is going to retrograde blood flow from the left atrium into the pulmonary vein all the way back into the lungs. What will happen? The lungs get filled with the regurgitant blood from the left atrium, and that will lead to what? Increased blood volume in the lungs. And you should remember that in physics, pressure is directly proportional to volume. So as the volume increases, the pressure in the lungs also increases, and that will give rise to what we call pulmonary hypertension. High pressure in the lungs is referred to as pulmonary hypertension. And once there's pulmonary hypertension, what is going to happen? You realize that that pressure gradient, pressure difference would force the blood, which is coming from the pulmonary artery, to return, because the pressure here is very huge. It is going to force the blood to return via the pulmonary artery back into the right ventricle. And it will only return because there is a pulmonary regurgitation. There is a pulmonary valve insufficiency. So that pressure will cause the blood to return all the way back into the right ventricle. So as the blood is flowing back through the pulmonary insufficient valve, the insufficient pulmonary valve, it creates turbulence. And that would happen in early diastole. We regard that as an early diastolic murmur. And for the fact that it's secondary to pulmonary hypertension resulting from mitral stenosis, that early diastolic murmur is referred to as the Graham-Still murmur. I hope that makes sense to you. Now, let's move on to the other parameters of our conceptual Citylara. Okay, so we've already spoken about the character and the timing, and to some extent, the loudness. So let's recapitulate on the loudness again. So for the loudness, for the high-pitch murmurs, they are going to be murmurs of aortic regurgitation. We know that is an early diastolic murmur. Murmurs of mitral regurgitation, tricuspid regurgitation, ventricular septal defect, that's going to be pansystolic murmur. Then the murmurs of aortic stenosis, pulmonary stenosis, we know that will be an ejection systolic murmur. So once again, you should know that for murmurs of aortic stenosis and pulmonary stenosis, you are going to have an ejection systolic murmur. For the murmurs of mitral regurgitation, tricuspid regurgitation, and ventricular septal defect, you have a pansystolic murmur. And that of an aortic regurgitation, you have an early diastolic murmur. So these murmurs are going to be loud. And if they are loud, which part of the stethoscope are you supposed to use? Definitely the diaphragm. Then we have the low pitch murmurs. And the low pitch murmurs, they are usually the mid-diastolic murmurs. For the mid-diastolic murmur, we said they are caused by mitral stenosis and tricuspid stenosis. And in that case, they are going to be the mid-diastolic murmurs. So mid-diastolic murmurs, they are low-pitched, as we said initially. So that will do for the loudness. All right, so the next thing we want to talk about is we have already talked about the character, the timing, the loudness. Now we are moving to area where loudest. So for the area where loudest, simply put, for the aortic stenosis, you are going to hear it louder in the second intercostal space, right sternal border, known as the aortic area. If you want to get more information on this, please watch our previous video with regards to the points of auscultation of the heart. Everything is detailed there, well explained. For the aortic regurgitation, it's going to be heard in the fourth intercostal space, left sternal border, known as the tricuspid area. That is the exception there. If we take the mitral regurgitation and mitral stenosis, they are both going to be heard loudest in the mitral area. That will be the fifth intercostal space, left mid-clavicular line. Then we take the tricuspid regurgitation and tricuspid stenosis. They both are going to be heard loudest in or at the tricuspid area. That will be the fourth intercostal space, left sternal border or edge. Then the pulmonary regurgitation and the pulmonary stenosis, both are going to be heard loudest at the pulmonic or pulmonary area. That will be second intercostal space, left sternal border. Now, let's move ahead and look at the next one, which is the radiation. For the radiation, pay attention very well. There are two murmurs that classically radiate. For those murmurs, we are looking at the pansystolic murmur of mitral regurgitation. The pansystolic murmur of mitral regurgitation radiates to the axilla. It radiates to the axilla. Please take note of that. And the ejection systolic murmur of aortic stenosis radiates to the carotid. Why am I saying that? Because look, this is the aorta. If it's ejecting and there's a narrowing, the turbulence is transmitted all the way to the aortic arch, and it will go through the branches of the aortic arch. And the branches, we know we have the brachiocephalic artery, which is to the right. You have the left common carotid artery and the left subclavian artery. So if you have the left common carotid artery, definitely that's a carotid. So the turbulence is transmitted through the left common carotid artery as well as the brachiocephalic artery. And you know the brachiocephalic artery gives off branches to the right subclavian artery and the right common carotid artery. I hope that makes sense to you. Now let's look at the last one. And finally of our Citylara concept, the accentuating maneuvers. Interesting, right? Very, very interesting. So for the accentuating murmurs, we are going to be looking at it from different points of view. The first one is the movements. The movements. So with the movements, we want to know which movement will help increase the loudness of the murmur. So in that case, there are two movements that can be done. So the first one, we can think of the left lateral position. The left lateral position increases the loudness or the intensity of murmurs of mitral stenosis. The left lateral position, that is the patient will be put onto the left, and if you are trying to elicit this murmur, you have to roll over the patient onto the left lateral side, and that would accentuate the murmur. So the left lateral position accentuates the murmur of mitral stenosis. And the leaning forward position, that will be used for aortic regurgitation, accentuates the murmur of aortic regurgitation. Why does the murmur get accentuated? Why? Because the movement brings the relevant portions or parts of the heart closer to the stethoscope, thereby accentuating the murmur. So that's what the movements do. Let's move on to the next one. That will be the process of respiration. We know respiration is made up of what? Two phases. We have the inspiration and the expiration. You should know that the inspiration increases blood flow to the right side of the heart. If you want to remember easily, remember right. R-I. I is the second letter after R. So right meaning R-I, we are talking about inspiration. So on inspiration, there is increased blood flow to the right side of the heart, and by so doing increases the turbulence, increases the loudness, or accentuate the murmurs of the right side. That will be which murmurs? The tricuspid regurgitation, tricuspid stenosis, pulmonary regurgitation, pulmonary stenosis. Those who constitute the right-sided murmurs. But if the murmur is already loud, there's no need to do such a maneuver. The next one is the expiration. Expiration, you are looking at E. And if you move here left, what's the second letter? Is E. So expiration increases blood flow to the left side of the heart. And if blood flow is increasing, then definitely turbulence will also increase. So left-sided murmurs are accentuated during expiration. And which murmurs are we talking about as left-sided? We are looking at the mitral regurgitation, mitral stenosis, aortic stenosis, and aortic regurgitation. Now, let's move ahead. The next thing we'll be talking about with regards to the accentuating maneuvers is the Valsalva maneuver. Then the question comes, what is a Valsalva maneuver? Valsalva maneuver in this regard refers to a forced expiration against a closed glottis. So if you are forcibly trying to breathe out against a closed glottis, then we'll call that a Valsalva maneuver. And you should know that Valsalva maneuver, when done, it decreases the systemic venous return. And by so doing, it accentuates the murmurs of mitral valve prolapse and hypertrophic obstructive cardiomyopathy, and softens the murmurs of mitral regurgitation and aortic stenosis. I hope we are getting that. Let's move to the next one. That will be squatting. For squatting, what does it do? Squatting has exactly the opposite effect of what? The Valsalva maneuver. Even though squatting also decreases the systemic venous return, it increases the systemic vascular resistance. And when it does that, it accentuates the murmurs of mitral regurgitation and aortic stenosis, and softens the murmurs of mitral valve prolapse and hypertrophic obstructive cardiomyopathy. So you can see the exact opposite effect existing between the squatting and the Valsalva maneuver. And finally, the last accentuating maneuver will be exercise. And you should know that exercise accentuates the murmur of mitral stenosis. Exercise accentuates the murmur of mitral stenosis. I hope you've gotten that. A quick recap, something very useful that you want to take is, if you take a murmur of mitral stenosis, then you should know that it's a mid-diastolic murmur, which is low pitch and rumbling. Therefore, when you are going to listen for it, you use the bell, because the bell are used for low pitch sounds. And make sure to place it gently on the chest, because if you place it tightly against the chest, the skin will be serving as a diaphragm, filtering out low pitch sound, making it difficult for you to hear the murmur. So what can you do to accentuate the murmur? In that scenario, we said there are certain movements that you can do. You are supposed to roll over the patient onto the left lateral side. And again, whilst you try to listen to the murmur, you ask the patient to expire and hold it there. Ask the patient to breathe out and hold it there. Why? Because expiration accentuates left-sided murmurs. And where is the mitral valve? Definitely, it is where? To the left. So the left-sided murmur, we say the mitral valve and the aortic valve, because they are connected to the left. They are relating to the left. The aorta is connected to the left ventricle, and the mitral valve is existing between the left atrium and the left ventricle. Those are left-sided murmurs. I hope that makes sense to you. Then again, if you are listening to the murmur of aortic regurgitation, definitely you ask the patient to lean forward, or you lean forward the patient. You put the patient in a lean forward position. Then you ask the patient to expire and hold it there. Why? Because expiration accentuates the murmur of what? the left side. And that would help you to hear the murmur louder. I hope that answers your worry. The last thing I want us to look at is the grading of the intensity of murmurs. So the murmurs can be graded from 1 to 6, whether systolic or diastolic. But remember that clinically, for diastolic murmur, it usually does not go beyond grade 4/6. It is only the systolic murmurs that you can hear, you can grade by hearing up to grade 6/6. Telling you that for the diastolic murmurs, they will end clinically at grade 4/6. But theoretically, diastolic, systolic murmurs all are graded over 6. But clinically, the diastolic murmur would end at what? Grade 4/6. It does not go beyond the grade 4/6. Let's have a look at the grading. Grade 1/6 means that the murmur is very soft and only heard after listening for a while. It means that you have to hold the stethoscope in place for a while before you can listen to that murmur. That is why whenever you are listening to the chest, don't be in a hurry in terms of murmurs. You have to wait for a while, at least 15 seconds. Go in. The grade 2/6, the murmur is soft, but heard immediately. It doesn't take time for it to be heard. Grade 3/6, the murmur is clearly audible. You can hear it clearly audible, but no palpable trills. Now somebody will ask, what is a trill? When we say trills simply refers to palpable murmurs which can be felt as vibration using the tips of what? The fingers. It's usually elicited using 2 fingers. At the tip of the fingers, you would be able to what? Feel for vibrations. If you are able to feel vibrations, then we'll say that is a palpable murmur, hence it is what? A trill. I hope that makes sense to you. Grade 4/6, clearly audible with palpable murmur. Grade 5/6, audible with the stethoscope only partially touching the chest. It means that if you don't even place the stethoscope completely on the chest, you can still hear the murmur. That becomes grade 5/6. And finally, grade 6/6, we are looking at what? A murmur which can be heard without placing the stethoscope on the chest. So these are the grades for the systolic murmurs clinically. And for the clinical grading of systolic murmurs, it will end at grade 6/6. But that for diastolic murmurs, it will end at 4/6. Meaning that for diastolic murmurs, they do not go beyond grade 4/6 with regards to what? The clinical grading. I hope that makes sense to you. Now, the last thing I want us to look at is the non-valvular murmurs. To conclude with, we'll be looking at the non-valvular murmurs. All that we've said before, you could see that they were related to the valves. Now we are looking at the non-valvular murmurs. They are not associated with the valves. For the non-valvular murmurs, the first thing we want to talk about is the pericardial friction wrap, which, of course, is what? Pericarditis. Then what then is a pericardial friction wrap? You should know that the pericardial friction wrap is a superficial scratching sound not related to diastole or systole. Okay? It is irrespective of systole or diastole. Take note of that. Now let's move on to the next one. Continuous murmurs. When we say continuous murmurs, it means that they are murmurs that are heard throughout the cardiac cycle, throughout systole and diastole. Continuous, it means without stop. And for the causes, you can think of PAR, P-A-R. So for the continuous murmurs, they are heard throughout the cardiac cycle, throughout diastole and systole together. It will be heard from systole to diastole, meaning that they are continuous without a break. And for the causes, you can remember PAR. Or if you are somebody who is a lover of music, you can remember rap. You can turn it upside down. So for the PAR, we are looking at the patent ductus arteriosus. The next one, arteriovenous fistulas. And the last one, ruptured sinus of Valsalva. You can also turn it upside down. That becomes ruptured sinus of valsalva, arteriovenous fistulas, and patent ductus arteriosus. Thank you very much for staying through till the end of the lesson. Kindly subscribe, share, like, and leave a comment in the commentary box and tell me what you would like to see in my next video. And remember that this is Concept in Medicine. Bye-bye.